Welcome back, everybody. We are ready to go, 10 o'clock, 10:03. I just want to thank again our speakers for the listening in part and sharing us their lives as older adults with all of the questions and new things that they're finding out and the joy that they have. Next up is our morning keynote speaker. And so I would now like to turn this over to Terry Dowling for the introduction.
Good morning again, everyone. It's my honor to introduce Dr. Louise Aronson. Louise is a remarkable UCSF geriatrician and professor and a prize-winning writer. If you haven't done so already, please read her Pulitzer Prize finalist book, Elderhood: Redefining Aging, Transforming Medicine, and Reimagining Life. For the past year and a half, while working with the San Francisco Department of Public Health, I was lucky enough to work almost daily on Zoom with Dr. Aronson and a number of other outstanding professionals. We provided COVID support and education to the staff and residents at the 99 licensed residential care facilities in San Francisco. Her powerful advocacy for older adults, her intelligence and wisdom, and her wicked sense of humor make her a role model for all of us. Please check Louise's bio document, which was emailed to you and posted in the chat. It is now my pleasure to introduce you to Dr. Louise Aronson, who will talk to us today about aging, ageism, and the future of elderhood. Louise?
Thanks, Terry. It is a pleasure to be here. And my wicked sense of humor, yes, I don't tend to behave the way maybe I should, but it's always good to be in an audience that appreciates it. So I'm going to launch into my talk here. Sorry, I was having multiple technical difficulties this morning, but hopefully this will work. And sort of talk about pandemic aging, how we can use this moment hopefully to make things much better for all of us. So it's been a heck of a couple years. That's not news. And I think what I'm going to focus on today is sort of what we learned from the response to COVID-19, none of which was really necessarily news, but it kind of crystallized things that we've known and seen and hopefully brought it to the attention of others in ways that will be helpful. Then consider how the way we talk about old age, even those of us who are really invested in it sometimes, can sometimes contribute to the challenges, and then identify some steps we can all take to make things better, hopefully. So this you're all familiar with. It is the curve of mortality by age. An interesting thing when you think about age, since people have very different notions about when old age begins, but according to COVID, it seems to be at the ripe old age of 45 when you start getting into trouble, which does also speak to the fact that aging is something that is continual and sort of accrues over our lifetimes. But also from this graph, it's very clear that the older you get, the higher your risk for COVID and for a variety of other things, including death itself. Equally, it became clear that age wasn't everything. So this was a study of people ages 75 to 84. So old by almost everyone's standards, and yet you can see the mortality differences were significant. So compared to whites, Blacks had a rate difference of nearly 900, Latinx elders over 500, Native and Asian and Pacific Islanders of 150 to 200. So significant differences by race with no biological reason that race would increase your risk of death. And actually there was a study in one of the leading medical journals which found basically that Black patients were more likely to die of COVID, not because of anything that had to do with either COVID or being Black, but because they went to hospitals where no matter what you went in with, appendicitis, an infected toe, whatever else, you were more likely to die because you got less good care. Frailty also matters. The very first outbreak was in a nursing home. By a couple months into the pandemic, which is this slide on the right, about half of deaths in many states were in nursing homes. And overall, it looks like for nursing homes alone, the number of people who died were 1 in 10. Now, people in nursing homes are about 4% of the population. Our lifetime risk is much higher, particularly if we are female or female identified. Um, and so people think of it, it's the exception, it's the thing that we don't want to associate with ourselves, but it's also kind of the quintessence, the culmination, the ultimate old age location and syndrome. So sometimes it works very well as a metaphor for how society is treating old age more generally. And that's where it becomes so clear that policies and priorities matter as much as biology. People think, oh, you're in a nursing home, you're on the way to being dead anyway. But it turns out that you were far more likely to die because there wasn't PPE, right? While they were putting it in hospitals, where actually you were safer than you were in a nursing home, they were not giving it to nursing homes or assisted living facilities. The testing wasn't available. We also know this is an essential mitigation strategy. Vaccination, even the one area where elders were actually prioritized, there was a different system than for everybody else. And so it went much more slowly than anticipated. So pretty much by every COVID metric, older adults became second-class citizens. And the rate ratios, you see the risk of death is much higher, and people look at these risks of death or of hospitalization and they think that's all biology, but it's really so much policies. Imagine if we had given KN95s to everybody over age 55 or 60 in this country, what death rates and hospitalization rates might have looked like. There are all kinds of ways in which it's not just about biology. And that is the truth of age itself. So often old age and biology get blamed for things that are in fact the products of our policies and priorities as a society. And age isn't a single category. This is something that I'm hoping the Centers for Disease Control finally learned in this pandemic, because as you can see, the risk of death goes up significantly with each decade. But there were also really big gender differences in who got hospitalized and who died, some places more so than others. This is actually data from Spain. So it really shows the way culture makes a difference. Men were at more risk in the US, but not as much so as in certain other countries. And again, that wasn't just biology. We know sort of locally, this is for California, that lots more cases in young people, lots more deaths in old people. But we also know that old age offered some pretty incredible opportunities in recent years. Particularly, you'll note the uniformity here of racial background and educational background. But it's interesting at a time where everybody's saying, oh, all old people live in nursing homes and all old people are dying. They were going to die anyway. Meanwhile, the people in charge of our government and indeed in charge of my hospital are all themselves in old age. So ageism was defined by Robert Butler as a process of systematic stereotyping or discrimination against people because they are old, just as racism and sexism accomplish with skin color and gender. Ageism allows the younger generations to see older people as different than themselves. Thus, they subtly cease to identify with their elders as human beings. Now, I will say that in some ways, when I was a young geriatrician, I also thought of older people as them. These are the people I take care of, sort of as if I was doing like global health. Okay, I go to Mali, for example, and I'm like, here are the people I'm taking care of. I'm not going to become Malian, even if I lived there my whole life. And yet there is this disconnect for pretty much all humans when we are young in thinking this will become us, and these are part of this is part of our lifespan. I do think that Butler made this a little biased, ironically, because ageism can also be against the young. I don't know about you, but I do sometimes have these thoughts of like, why are they always walking around crossing the street, looking on their phones and not looking up? Maybe that's an ageist thought on mine, might be. Ageism was kind of made part of our world in the last year and a half. So this was a major article in Time magazine, The Road to Recovery, How Targeted Lockdowns for Seniors Can Help the US Reopen. So it's othering, right? So there's seniors and there's the ironically sort of initials of our country. US is like us. So there's us and they're the seniors. So we'll incarcerate them and that'll allow the rest of us to go on with our lives. Can you imagine, like, let's lock down the men because they're at such high risk compared to women, and we're going to go on with our lives, or any other group. You just wouldn't see it, certainly in our neck of the woods in this era. There were people on Twitter saying, you can call me a grandma killer. And again, you see that separation of us versus old people. So this woman's picture shows her holding a baby. So she is what a colleague of mine would call a grandmother in training. And yet she's saying, you know, call me a grandma killer, no big deal. And then the ethicist Peter Singer, who was recently profiled in the New Yorker and then won a very prestigious award, asked on the day of George Floyd's funeral in an international publication whether age discrimination was acceptable, and he concluded that it was. Bob Butler went on to say about ageism that it includes prejudicial attitudes towards older people, old age, and the aging process itself. So we saw this again in COVID, testing slow to come to nursing homes, 35% of COVID deaths. Like here in liberal California, where we're always thinking about underserved people, we were not sending testing to the place where one could easily argue it was needed most. Indeed, the governor wanted to cut all home care services, not realizing that most long-term care, most care services are in the community. So his thought was, well, people shouldn't go in to see older people, so we'll just not pay for those services because they can't give them anyway. Not thinking it through, right? It's so far from most people's thoughts that not thinking like, well, they actually have those services because they need them to survive. And if they don't have them, they'll go into nursing homes where we're having all these big outbreaks. I mean, the illogic of it just probably wouldn't happen for another group, although I suppose it does happen for a variety of groups. But luckily, we all pushed back against that and it did not happen. And then there was the federal policy that nursing homes did not have to report deaths before May of 2020. So quite literally, the lives of those older people were not counted. Actually, until just recently, there was an article 2 weeks ago by a Harvard team counting the deaths that hadn't previously been counted. In their preliminary analysis, there were 16,000 deaths uncounted and 64,000 cases uncounted in that first wave. So now those lives are being counted. PPE, so this is an assisted living facility in San Francisco. And when we went there, we were told by the executive director that he couldn't get PPE and that he had emailed all his friends across the country and asked them to go to their local Costco or Walgreens or wherever else and buy as many masks, as much sanitary stuff as they could find and mail it to him, and he would pay their postage because he was that desperate to get needed PPE. And this was while they were having an outbreak. People were having to wear the same things from the sick residents to the well residents because they were not prioritized despite the abundant data for the PPE needed. So Bob Butler's second point was that was about discriminatory practices against older people. And one could argue that all of this was discriminatory, but to be more precise, you know, who's in charge of the pandemic? Well, the Centers for Disease Control. So really interesting. If you looked at their public facing page for most of the pandemic until vaccines were quite common, you saw this. So things you need to know, symptoms, testing, vaccines, you know, all the sort of stuff you would want to know. Interestingly, they do call out age because as you'll see towards the bottom, there's a category called children and teens. And if you press the little plus next to that, you find 9 items. So really important. Yes, children and teens not getting COVID so often, really rarely getting sick. That is a totally wonderful thing compared to the pandemic in the 1900s, you know, not killing children. We can all sign on to that, right? And great thinking about the other ways in which children were being harmed by pandemic, not being able to go to school, not being able to see their friends. But it's interesting when you cut things down by age, right? You sort of have adults and then you pull out children and teens, but you don't actually pull out the group by far at highest risk, and this page continued well towards the summer of this year. So the group with the 80% death rate not called out, which is kind of interesting. They were there, but they were buried under people at increased risk. And even then, it was about having certain conditions, needing extra precautions, and not even really precisely about old age, with all the things that we know at a glance are different physically and socially between an 8-year-old, a 48-year-old, and an 88-year-old, for example. They did improve it somewhat in the late spring, but basically aligning it with people with a variety of increased risk factors, not one of which was as high as the increased risk factor of age itself. Treatment and vaccine trials, also older people were excluded. We all know that vaccines for people ages 12 to 17 didn't come along right away when we adults got vaccinated. Why? Because they were testing the vaccines to make sure it was safe, and were, awaiting vaccines for even younger kids right now. What was the one group that was actually vaccinated without any trial data showing safety and efficacy? Oh, right, older adults. Not because there wasn't time to include them in trials, but because it simply wasn't done. And then the argument was, well, they're at such high risk, we're going to give it to them anyway. Now, on a positive, they got lucky. But let's be clear, that wasn't good science. That was dumb luck. Thank goodness, but still, they could have included people in trials, except for they really didn't know how to do that. And there were exactly no trials in the long-term care facilities that were the very first places where vaccines were given. Bob Butler's number 3 was that institutional practices and policies that perpetuate stereotypes about elderly people are a big part of ageism. And again, we definitely saw this. This was an article in New York Magazine that no one should be surprised that America abandoned the elderly to die, and sort of goes through our history of treatment for older people, or rather not treating them separately, but much less equally to how we treat children and adults. And the interesting thing there was how the conclusion was principally about the governors of New York and New Jersey, but talks about how they looked at the risks and they basically shifted the burden to those least able to shoulder it, by which they mean older people were more likely to get sick. This was in the first big surge, right? On the East Coast, people of all ages were getting sick, but younger people will often bounce back more quickly. Older people can bounce back just as much. It often takes a little bit longer. But so they weren't clearing out their hospital beds. And although the vast majority had been independent living people in the community, they then needed help. So what did they do with them? They took them with their active COVID and sent them into nursing homes. Nursing homes that did not have PPE, did not have testing ability, did not have separate wards for people yet. None of that had been figured out. So they took the people with COVID, sent them into the nursing homes, often then didn't accept transfers from nursing homes to hospitals. And so that is why people died. So again, yes, age poses risk, but policies lead to death very often, including in this case. And yes, there are lawsuits in progress now. So that one could argue there were 9 key elements of the pandemic response, and there was one area in which older adults were prioritized, and that was vaccination. But realized that they were prioritized, but there was a separate, less effective system for vaccination. Contracts with Walgreens and CVS, 2 pharmacies that had no experience with long-term care. Meanwhile, the people who made these decisions had no idea that there are pharmacies that have been dealing with long-term care forever. They just bypassed them for ignorance. Imagine knowing that little about another age group. And as I said earlier, yes, prioritize for vaccination, but without any trial data. So really structural ageism from soup to nuts here. Okay, this is another comment on ageism, this from the Ontario Human Rights Commission, which has some really good thoughts on this topic. They talk about ageism as a tendency to structure society based on an assumption that everyone is young, thereby failing to respond appropriately to the real needs of older persons. And we see this in lots of ways. I always like to reference back the very first iPhone, which was made a perfect size if you were a young man wearing a pair of jeans and you wanted to put your phone in your back pocket. It was only after they had been sent out into the world that people realized that women weren't sure what to do with it because they didn't have that kind of pocket. And eventually the world adapted, as did Apple. But so often people make things in their own image, not realizing that others might have different ideas. Um, and one of the problems with old age here is that often people aren't as involved as they might be. We've actually seen this in medicine where we got women's health in the 70s and particularly 80s and 90s as women entered medicine. As the medical profession has become more diverse, we have a lot more focus on influences of race and structural inequalities on health outcomes and health care. But I don't think, and I wouldn't advise it, that we should have people in their 70s, 80s, 90s, and 100s going to medical school. It's hard enough in your 20s. So disease presentations. This will be too much data for some of you, but basically this was, not even people who think about old age. This was a group of people who do emergency medicine. And what they found was 1 in 3 older adults presenting to their emergency room. And by older, starting at age 65, not like people over age 80, just everybody over age 65. 1/3 had delirium, which means confusion was the presenting symptom. And almost 40%, so 2 out of 5, did not have any classic symptoms, cough or fever. We actually knew this before the pandemic hit the United States. This was data from China and from Italy. It still has not appeared on the CDC guidance or anywhere else. And there is an abundant literature. I have some citations down there for those of you who are in healthcare. That's just a few, but there is a huge literature on different presentations in older adults. Moreover, we have known that older adults present differently with many things for decades and decades. And yet the minute there was a different presentation in children, that hit all the guidelines. But for older adults, it never did. And indeed, at my institution, ranked the best healthcare center on the West Coast, we only ever had algorithms for adult and pediatric patients, despite a huge literature. And yet we claim to practice evidence-based medicine. Now, I realize this is a very medically focused topic, but I would challenge each of you to think of your realm and think of analogies. I mean, this is what I do, so I see these biases every day, but think about other ways in which in your sector of the world, things are really skewed towards kids and adults with no consideration of elders. And think of the way that structure leads to harms. It becomes a self-fulfilling prophecy. And so here's another example. Hospitals would allow visitors for people, essential care partners, if you were a kid, if you were in labor to have a baby, if you were dying, if you were having surgery, but if you had dementia and you were going to become really confused, if your family member wasn't with you, and I know that we had to stay with my father 24/7 whenever he was hospitalized as a result of his dementia, or he would get tied down or drugged or hurt himself. So rather than having the same accommodations for this known high risk group, they were drugged and tied down, leading to adverse health outcomes. Meanwhile, we also said the best way to protect older people was to isolate them, not to give them really good masks and other things. And so that came on top of a crisis of social isolation and loneliness that already existed. And so the consequences of these policies were often excess mortality. People who were having heart attacks and were so scared to go to the hospital and get COVID that they died of their heart disease that probably could have been treated. There are people who stopped eating for hopelessness. There were all these ways in which some of the policies that made sense in the first few months no longer made sense, and the expertise in aging and in the specific needs of older adults was not harnessed in the same way it has been for other age groups, which is not to say that the way we've dealt with children and their educational needs or adults and their working needs has been perfect, but there has been more attention paid to it. On a more positive note, appropriate responses save lives. So you can see that once vaccines were introduced almost immediately, like the first COVID vaccines into nursing homes really were in January. And by February, the numbers of deaths plummeted, right? It really made a difference. This is a place where science can really transform. And similarly, looking through May, you see that you start seeing more deaths in younger people and fewer deaths in older people. Because when you prioritize the people at highest risk, they stopped being the people at highest risk. Okay, moving now to part 2, which is to think about how the ways we talk about and approach old age might contribute to the challenges and contribute to the responses we saw to COVID-19. So there are a variety of narratives we use. One of them that's very popular, certainly in Marin and also in San Francisco, probably in the Bay Area, more so than most other places on the planet, is, eat your blueberries and kale, and you as a good American will not grow old, and you don't even have to die. Sorry to inform you that this is not true, although these things really are good for you and can delay frailty and improve what we call your health span, which is the period of time during your life in which you are healthy. So great things to do, but not going to solve the fundamental problem. Next popular story is the exceptional elder narrative. So that's where we hold up like, wow, anybody can run a marathon until they're 103 because this one guy in India did. The problem with exceptional people is that they are exceptional. And so it might be they're actually different from most of us. And also when we look at them, we think, oh, they're different. Oh, that's not me. I would say to the males in the audience, how many of you had abs like that at 20 or at 40, much less at whatever age that man on the left is. And I would say to myself that if I did the splits like that, I would require orthopedic surgery. So these are not models that actually help me with my own healthy and positive aging. And then worst of all is this notion of silver tsunami. Yes, it's actually very witty. The problem is shown partly in this photograph, which makes all old people into a generic mass, as if 65 equals 75, 85, 95, 105, and even 115. That is a half century of life. There is a huge amount of change in a half century. It's not a generic group. You also see that this pits the children versus the old people as if we're all not part of the same larger ecosystem and social system. And it suggests that old age only brings badness to society, no goodness. This as we live in a society where no one wants to die. So it makes no sense. This is very blurry. Sorry about that. We also tell these stories that are fun and funny, but not so true. Like age doesn't matter unless you're a cheese. I don't know. I think anybody over 45 would beg to differ if they were really being honest. Age is always 15 years older than I am. I think many of us have felt that way. And yet at some point you just are old. Then there are things like how not to become a crotchety old man. Which, yeah, you're probably a happier person if you're not crotchety. So it could be, oops, sorry, my mouse here. So it probably could be wonderful to hear about that, but it reinforces the stereotypes and how not to become a little old lady. Well, the fact is, if you live long enough, you're going to become smaller. Your arches will go down, the amount of fluid between your joint spaces will go down. You will become smaller, but that's okay. So this is from Boston's Age Strong Commission, which is Boston's anti-ageism campaign. They are trying to reform the language of how we talk about old age, but I actually think they make it worse. And this is one of those things that we all often do inadvertently. So yes, I'm calling them out. And I think it's useful just to think about the ways we might all be a part of this. I know once I entered my 50s, I began making comments that I rarely make any longer, but I had to train myself not to. It's normal. It means we're healthy members of this culture. So this woman who, is a gorgeous 86-year-old says she's many things, but over the hill isn't one of them. Well, if you think of the hill like most hills are, they go up and they come down, which means the midpoint is usually, you're over the hill once you've passed the midpoint. So depending on how long you're going to live, there are people in this country, and it's based on geography, sex, and race, where life expectancy is 70. And so you'd be over the hill at age 36. There are other people who are more fortunate and it would be over the hill beginning in their 40s. She's already made it to 86, so who knows where her over the hill began, certainly after age 43. But there can be no question that she's over the hill. Wouldn't it be far better to live in a world where being over the hill, where the second half of your life wasn't a bad thing, rather than saying she's not over the hill? They're arguing that over the hill means useless, and she's saying I'm not useless. But far better to just have it be a world where being over the hill is a great place to be. You know more, you've experienced more. It's a wonderful thing. And sort of related to this is this 83-year-old guy who says he's many things, but he's not frail. But I think the clinicians and probably everybody else can look at him and say, he may not be frail yet, but he's getting close, right? He's going to be frail. And if he's saying, I'm a worthwhile person because I'm not frail, does that then mean that once he becomes frail, he becomes a not worthwhile person? Wouldn't we all rather live in a world where we're still considered worthwhile, where our humanity is still seen and valued, even when we become frail? And yet we see this everywhere. This is UCSF's diversity poster, or at least the diversity poster from a couple years ago. So we welcome all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities. But if you're old, we're not so interested in you. And so one of the jokes I like to make is, well, at least it's honest. So it would be nice if we could consider age part of this spectrum of all the ways in which we differ and should be valued. And yet it is true that older people are devalued in medical education and in healthcare and in society. So in medical education, at least for doctors, it's a 4-year process. Generally, people get about 3 months total learning about kids, and maybe, if they're lucky, about 2 weeks learning about older adults. Now, that's especially interesting when you consider that kids are 22% of the population and older adults are 17% of the population. So if you went strictly on numbers, that proportion would make no sense. If you then actually add in healthcare system usage, you will find that kids are for hospital stays only about 6%, but they do use a lot of outpatient services. So again, you'd probably want a fifth of your time devoted to kids. And for older patients, older people who are 17% of the population, there are actually 40% of hospital stays and anywhere from 30 to 80% of outpatient medical and surgical practices. So you'd want a heck of a lot of more attention to old age than we currently get. Again, not represented there, but when you think of systems saying, hey, we're paying attention to demographics now, or hey, we're trying to meet the needs of society, you can make a really good argument that this is not happening. And it's not just for doctors. Nurses about, I'm trying to think when, within the last decade, shifted from having specific training in geriatrics for nurse practitioners and other nurses to combining it into adult and geriatric. The positive there is everybody learns a little bit about old people, which is a really good thing. The negative is nobody learns a lot about old people. Unlike kids where they are at least allowed to specialize. It's even worse when it comes to social work or physical therapy or occupational therapy, areas where people see disproportionate numbers of older adults but are given very little training in it. In the public health sector, this is kind of funny in a tragic sort of way. So you saw the CDC graphs about COVID, right? So it showed by decile, in your late 40s, your risk goes up, and then onward and onward, getting bigger with each 10-year interval. And yet the 2021 vaccine schedules, and you're not meant to be able to read this, but we basically decide who needs which vaccines based on three things: your social behaviors, your biology, and your immune system. And that means for kids, because kids change a lot over the first 18 years, there are 17 subschedules. For adults, as you see on the right, there are three subschedules. They're the people from 19 to 26, people from age 27 to 49, and the people in middle age from age 50 to 64. But then there is this category, this monolith of 65 plus, which makes no sense socially, biologically, or immunologically. So this is blatant, bald-faced, second-class standard for older adults. Medical research, we've seen something different. So some of the stuff that's led us all to be here now, to living as long as we do, some of the best research started taking place in the last century, in the 20th century. But by the 80s, they had noticed something, which was when you did the studies the way we already did. When you're doing science, you want to control as much as you can. So they tended to control it by taking people of a fairly narrow age range, taking males because they didn't have those weird hormones that happen to us females, and pretty much just white people because, sort of made in your image. So you had basically white heterosexual males between the ages of 20 and 60 participating in research. And what they noticed initially was that when you applied the results of that research to another big category, say females, they still did better than they did without treatment, but they didn't do nearly as well as the males because it turned out they were different. So the very same thing that led to their exclusion from the trials was why the trials weren't as useful in providing guidance for how to take care of those people. So in the late 80s, the NIH said, hey, look, if you're studying a procedure or a medicine that you're going to give to females or people of color, you need to include those people in your research. And that led to better research. In the 90s, they discovered that children were different from adults. And so they mandated that you include children in studies when you were going to apply the results to them, because guess what? A little 2-year-old does respond differently than a 42-year-old. When did they include older people in this research? 2019. So that was the first mandate, even though there's such disproportionate use of healthcare by older adults. In healthcare, we also see this phenomenon where we get children's hospitals and, of course, adult hospitals. But what do we get for old people? We get something called age-friendly health systems. The bar here, so I guess two things to say about that. One is it's making a huge difference. I'm not devaluing what's being done. It's tremendous because it's focusing on four things mostly. What's most important to this person? That really matters, especially as your time horizon gets smaller. The risks of things go up and the benefits go down. Medications, because they do so much harm in older people, partly because they weren't studied in older people, but they're given to them. Mentation, like how our brains work, and mobility, how our bodies work. So really important things, and yet the bar to get labeled an age-friendly health system is just to have some part of your system paying attention to these four things. Really different from having entire hospitals with specialists and subspecialists in your age group. Definitely a lower standard. And so we come again to the Ontario Human Rights Commission, which says from a human rights perspective, there is a lack of sense of moral opprobrium linked to age discrimination, which in comparable circumstances would generate outrage if the ground of discrimination were, say, race, sex, or disability. See this all the time in students and in colleagues. If you ask them to then substitute race or sexuality or sex or something into the same phrase they have used about an older patient, they do tend to appreciate that while often unintended, they were being blatantly discriminatory. And this matters too for our individual health, and for our society, because internalized ageism does us harm. There is a researcher called Becca Levy at Yale who has done tremendous work in this area. Another guy called Ruben Ng in Singapore who's following suit, but really looking at how you think about old age, how that affects your health. So this graph just shows that you will have your first cardiovascular event, your first heart attack, your first stroke, 7.5 years later on average, if you think positively about old age. Now, we think there are two reasons for this. One is obviously, if you have a more positive attitude, you're going to take better care of your body. You're not going to think like it's game over. I'm going to sit on the couch and eat ice cream for the rest of my life. You're going to think, okay, I'm going to eat my fruits and veggies. I'm going to get out there and walk. I'm going to take care of this body because it's going to make a difference if I do. That's one mechanism. The other is, and we know this from all kinds of prejudice, when you are prejudiced against your own self, that is a state of high stress, right? And distress. And those things elevate a hormone in your body called cortisol, which increases inflammation, which puts you at risk for a whole array of diseases and conditions that can shorten your lifespan and your health span. So these researchers found also associations between having, positive notions of old age and recovering from disability, right? You're more likely to get better, and with how long you live. So, and there's so much more. So it really matters how we think about old age to our individual lives, as well as to our larger society, as we've been discussing. We also tend not to sort of put the more positive attitudes in front and center. So this was an article in my favorite medical journal, actually, the New York Times, by a psychologist who reviewed all the data to show why older people on average managed to stay happier in the pandemic. And there's actually been lots of scientific literature about this as well. It's not that everybody stayed happier. The highest risk people, the people in institutions, the people who already had mental health issues, the people who are more isolated, they actually did worse. But a lot of people did better. And that's because on average, people age 50 plus have more positive emotions in a day and fewer negative ones. How often do you hear that? How often do you use that as a rebuttal to people who are talking about old age? I think it can be really helpful to say, hey, yeah, some of the physical changes, the bodily changes, none of us are very excited about that. But there are some really good things that happen with age. And they happen across most communities, although there is less data on the truly impoverished, on immigrants, and on people in rural settings. But again, there is lots and lots of data about resilience and positivity and adaptability of older people in COVID and generally. Okay, so we will finally come briefly to some steps we can all take to improve elderhood now and for future generations. So there is this tech will save us approach. I'm not totally convinced. This is a very medicalized life. Like you sit on your bed and you take your blood pressure. There are these little animals they make that entertain people with dementia and actually some people without. There are machines that might help lift people and thereby also helping caregivers not strain their backs. But they're having trouble finding them in ways that work with older skin, which is prone to tearing. And then there are this is a robot nurse. Like this is not a real person. The one on the lower left, that is a robot. So a lot of these things come from Asia and the Scandinavian countries who are a little bit ahead of us on this. I don't know that it will save us, but I would say that we all need to participate in the development of this technology because it's going to happen anyway. And if it happens, including the input of people who are or care about older people, I think it will be more useful to older people. There's a lot of stuff that is to calm down the guilt and worries of middle-aged children by imposing sort of, draconian big brotherist supervision on their parents. I don't think there's any age at which a person really wants somebody else to be looking in on them and knowing everything they're doing. And it also sort of predisposes no need for privacy in older adults, like that nobody's having sex, that nobody, is having dates they might not tell people about, so all the many things that we all do and that most of us hope to keep doing into later old age. There's also the science will save us approach. And there is this, it's a whole other topic, but there is this whole exciting area of geroscience, which might well delay frailty and slow the progression of lots of age-related diseases. It's kind of exciting in that medicine, sort of the 20th century model, really focused on, oh, you have diabetes, let's treat that. Oh, you have cancer, let's treat that. And this gets to something more fundamental that will lower your risk for all those things combined. So very exciting, not ready for prime time yet. And actually, we actually have one thing that already does this, that we can all do right now, and it's called exercise. It has the same benefit as all these fancy molecules. Benefits look like this. So they're on the left, you have one primate, and on the right, you have another. They are both 26 years old. The one on the left has had normal aging. The one on the right, I, as a food lover, am sorry to report, is the one who had the very low calorie diet during its lifetime, and regular exercise. So maybe lowish calorie diets, and some regular exercise really does delay aging. So there are some things we could do better as a society and as individuals. And this is just to show you some of the more molecular stuff, but also to show what the goal is of this science is to move you from the black curve to the red one, which means you have more years where you're healthy and a much shorter period of time of disability and dependence. And once again, the thing that does this right now is exercise. I'm just going to conclude by briefly going through what the World Health Organization has told us about healthy aging. And I'm actually going to do it backwards because it leads from, it just leads, it's more positive. And I also wanted to point out their definition of healthy aging, which is being able to do the things we value for as long as possible. This kind of stretches across people of all backgrounds in all locations, in a beautiful way. What is it that matters to you as a unique individual in the world, and how do we help you do it for as long as possible? Well, one thing is we need better systems for long-term care. I think, that is so not news, but the pandemic has led to all kinds of really good bills. It's in the package from the feds. There are all kinds of bills in front of the California state legislature. Get on board at supporting these things. We can really make a difference. We saw the pandemic started, the first outbreak in a nursing home. We saw the numbers of deaths. This was the recent study I talked about earlier with all the uncounted deaths. It really does matter, and we can do differently next time. In fact, if you look at the so-called greenhouse long-term care facilities, better staff retention because they get better pay, and the people who live there are happier. You get to eat whenever you want. You don't have to have dinner at 5:30 in the afternoon. They continued to have activities because they were in smaller groupings and the rates of COVID were much lower. So the VA system has now signed on to only build these smaller facilities, and the state of California is looking very seriously at it. So give them a big thumbs up for that. We want to align health systems with the needs of older people. I basically sort of already discussed this, but let's not keep talking about just kids and adults. Let's not train everybody on, delivering babies when 3% of people ever do that again, but 93% deal with old people in their careers. Let's align medical training and other forms of training with the demographic needs of our population. Get the CDC on board. If you're going to call out kids and adults, let's give equal treatment to older people. And acknowledging throughout healthcare and throughout all other parts of aging that 65 is different than 75 is different than 85. And yes, you can get 85-year-olds who are healthier than 65-year-olds. So do we also need to look at the individual in front of us? Of course we do. But we know in all age groups that there are some generalizations. You can pretty much faithfully distinguish somebody in their 20s from somebody in their 50s, somebody who's 2 from somebody who's 12, somebody who's 67 from somebody who's 87. And yet we acknowledge it for kids and adults and not so much for elders. I think on the medical thing, we need to focus more on healthy aging, and we as a society need to think about that. My profession has been remiss. They have said there's so few of us, that we're only going to deal with the oldest and most disabled, which means that we're all allowed to get sicker and less healthy because nobody's helping us age well. But we're starting to pay more attention, and the more everyone can clamor for this, the more likely we can restructure care to focus more on our health and less on our medical needs after our health has failed. It's not that we don't need the second one, it's It's that if we had more of the former, we would need less of the latter, and that would be more in keeping with what we all want as individuals and what the society needs from its aging population. We want to create age-friendly environments for all of us to live in and age in. And so I would just reference the age-friendly communities approach. I have a few nits to pick with this, like civic participation and employment seem to me really different things. So I actually would separate out some of these things, community support and health service. So if you're doing this as a county, think about, make sure that when you don't ask about things together, you miss out on one of them. We actually teach this to our students, like you don't want to ask a patient, have you had any chest pain or shortness of breath? Because if they say yes or no, you don't know which one, right? Have you had chest pain? Have you had shortness of breath? Like, are you voting? Are you working? These are really different questions. And it starts with little things like, are the door handles ones everybody can use despite their arthritis? Are the bathrooms made so that anybody can use them? They don't have to be ugly to be of use to people who are children, who are disabled, who are really pregnant, who've broken their leg, who've had a stroke. Why not make it so everybody can use it? Why not have that be the standard? Similarly for parks, why do we have areas for adults and kids to play and very little for older people? We're starting to see pickleball, mostly in wealthy suburban areas with mostly white and Asian populations. That needs to be ubiquitous. We all need to have opportunities to be healthy and to work on our health as we age. And we also live in this crazy world where people say, oh, old people are a burden because they don't work, and yet they don't want to hire older people because they're old. Pre-pandemic, people in their 70s were the fastest growing segment of the workforce, and some of that had to do with economic need, and some of it had to do with the fact that we don't die at 67 on average anymore, and that work is a really wonderful way to bring purpose, meaning, and social engagement to your life. Although I think we can all agree we'd rather, work maybe 20 or 30 hours a week instead of 60 or 70. Why are restaurants so noisy? Why does tech assume old people aren't going to use it? So many ways we can make this world better. And I do think we made huge advances in tech for many people, not all people, during pandemic. And finally, if we change the way we think about aging and older people, we will create a society that sees people of all ages equally. If you Google the human lifespan, you will often see this, where you've got infant, toddler, child, and teen, and then you've got a variety of adults from young adult to middle-aged. And then I would say the middle-aged person is the penultimate person here. And then, right after that, you're in a wheelchair. In fact, the human lifespan looks more like this, and you may never be in a wheelchair, or you might be in a wheelchair from age 2. So really making an accurate portrait of old age and showing the gradations of it the way we already do for childhood and adulthood could be transformational. And then just a few quotes that I really like to end on. This was Ursula K. Le Guin, who died a few years ago, but who said, "To tell me my old age doesn't exist is to tell me I don't exist." It's kind of like when people say, oh, age doesn't matter. It's kind of like saying race doesn't matter. You can only say those things if it's not mattering in your life, which is a temporary position in most cases, or maybe a delusion. She also said this, which is my favorite quote: "If I'm 90 and believe I'm 45, I'm headed for a very bad time trying to get out of the bathtub." This you may recognize as the anti-ageism campaign from San Francisco. You can see the people's current age, where their eyes are, and then their previous selves above and below. And it's to remind us that in every adult is an elder in training, and in every elder is an adult who matters. So I leave you with this very last thought, which is, what if the greatest limitations of aging come from our imaginations and policies and not our physiology? And thank you for your attention.
Oh, Louise, thank you so much. Let's have a round of applause for Louise's presentation. So much food for thought. And I think the critical piece here is that, more importantly, action is needed to be aware of ageism, to know that there's things that we can do within our own work and our own life to reduce the stigma of ageism. Oops, sorry, phone bad. So we don't have time for questions. I'm sorry, we have a few minutes for us to come back for an 11 o'clock session. But Louise, I'm so grateful for your having spent time with us this morning. I think we'll think about this for a long time to come. Thank you.
Yeah, I think we can all make a difference.
Yes, I do.
Thanks.
Thank you. All right, everybody, take a break, come back in about 5 minutes.